Hi team. Today we're going to talk about vestibular history and occupational profile. So last week we talked a little bit about why it's important for an occupational therapist to be involved in vestibular care. And right here is one of the reasons why I think it's really important. I think occupational therapists are the best at finding out how the vestibular impairment that a person has is impacting their occupational performance. And that's what it's going to be all about today. So here's what we're learning: how to distinguish between some different types of vestibular dysfunction based on the medical history, the client's reports, and analysis of performance. Once you know a little bit about why this person is coming to you, you may not have the whole picture, because sometimes a doctor might send someone to vestibular rehab with a diagnosis of vertigo. Well, vertigo isn't really a diagnosis, it's a symptom, and the vestibular issue or not a vestibular issue that might be causing the problem can be widely varied. So it's important to take a careful history, which is exactly what our textbook was talking about in the chapter for today, in order to figure out what in the world is going on with this person. So what do patients complain of when they have a vestibular impairment? They complain of vertigo. Now, vertigo is simply a symptom that means a sense of movement where there is no movement, or an illusion of movement. It's like when you're in your car at a traffic light and the person beside you starts to roll backwards and you slam on the brake because visually you think you're moving forward. Now, when that is caused by a vestibular issue, it's a little bit different. The person experiences it whether their eyes are closed or open. Different types of vertigo might be caused by motion or might not be caused by motion. They might be present at all times. But at its basis, the definition of vertigo means a sense of movement where there is no movement, or an illusion of movement. So how about when they have dizziness? What is dizziness? Dizziness is a combination of things, and you really have to kind of question a little further to find out: are they lightheaded? Are they off balance? Or do they have true vertigo where they have this sense of motion? So oftentimes I'll ask them, do you move? Do you feel like you're spinning, or the room is spinning, or rocking? Or do you feel like it's more in in how your feet are meeting the floor? I used to know a doctor who would ask them, are you dizzy in your head, or are you dizzy in your feet? And not everybody understood what that meant, but sometimes I'll resort to that when I feel like that might draw something out of a client. But lightheadedness is typically, people will talk about that if it's more of a blood pressure issue. I just feel like I'm going to faint. I feel lightheaded. So you have to try to split out those symptoms a little bit when you're taking that hit. So what do patients complain of when they have a vestibular impairment? First of all, they might say they have blurred vision. Now, why would that be if the problem is in their inner ears? Well, if you remember the vestibulo-ocular reflex, the thing that stabilizes our vision when our head is in motion faster than 30 degrees per second is not our vision, it's our inner ears. They help us to keep our eyes on the target. So if we're in motion, or if things around us are in motion, and by the way, we're almost always in motion whether we think we are or not, it can make our vision feel unstable if we have a vestibular impairment. If you think about it, even breathing or nodding your head in a conversation or glancing at the clock on the wall, all those things involve head movement and can destabilize someone's vestibular system if they are having inner ear problems, which makes them see blurry. People also may complain of a hearing loss. This is with particular kinds of vertigo, and it's of special note if they do say they have either a permanent hearing loss or fluctuating hearing loss, because that means there's something else going on in the inner ear besides just the vestibular system. It means that the auditory system is impaired as well, and that is a surefire way or reason to refer them to an ear, nose, throat doctor and an audiologist who can check out their hearing and what else might be going on. They also might complain of nausea, and With nausea, that's because of that strong vagal nerve connection with the vestibular system. When the vestibular system is upset, the vagal nerve is pretty unhappy too, and so it creates the stomach problems. Same reason why you get nauseous if you ride one too many fair rides, because the vestibular system is annoying that vagal nerve. What else do people complain about? Sometimes they talk about cognition as being not as sharp. Like they can't remember their kids' names, or they can't remember what they walked into the room for, and that's happening more frequently than usual. I tell them that's a normal side effect of having a vestibular impairment, because it is. I explain to them how our memory system is a lot like a stovetop with 8 or 9 burners. We can keep all these bits of information simmering at one time, like what am I fixing for dinner? What's the way home? I need to stop at the store and get this. I have to remember and tell so and so that. Those things can keep all together in our brain at the same time. But if we have a vestibular impairment, 4 or 5 of our burners are taken up with just keeping us upright in space. And that can be very disconcerting to someone, to have those cognitive problems. And that can be without a central loss. Now, yes, there can be some cognitive problems from a central loss as well, and that might be something that we have to work at splitting out with our conversation with them. But understanding that cognition can be part of a peripheral vestibular impairment is really important for us. Also, balance and coordination. Obviously, the vestibular system, one of its main goals is to manage our posture and keep us upright when both standing still and in motion. And if people are having trouble with balance and coordination from their vestibular system, that is to be expected. Now, the quality of that can help us determine whether or not it's central or peripheral. If it's an ataxic gait, where the person is having coordination problems with their gait, tremors, unsteadiness in a jerking kind of way, that would be more central. But what you see a lot with vestibular only peripheral issues is veering, a lot of veering to the side and unable to control it, or imbalance with a complete loss of balance when turning their head. Another thing we'll often see is a rise in emotions. The vestibular system is intricately connected with the limbic system, and therefore we tend to have very strong emotions surrounding vestibular impairments, and that's normal as well. And you might have patients who are just a little closer to tears than usual because of their vestibular problems. So what is balance? Balance is what a person takes in through their eyes, what they take in through their ears in the vestibular system, and their proprioception, generally what they're feeling in their feet and their joints. And so the vestibular system itself, though, these are the aspects we talked about last week in the anatomy: the inner ear labyrinth, also the vestibular nerve, the vestibular nuclei in the brainstem, and then the vestibular projections, which of course go to the cerebellum, to the cortex, to the limbic system, and to the vagal nerve as well. So here are some ways in our history that we might know that a person has peripheral vertigo. It would most likely be a sudden onset, and oftentimes there's an illness or a trauma, or sometimes just unknown, just out of the blue. The person will report a constant dizziness that's provoked by motion. It's fairly strong and uncomfortable for them, and it's worse with head and body turns. They also have discomfort with watching movement or patterns. And this is why you must not wear things with wild patterns on them when you are working with vestibular clients. And they also will report that they have mild to moderate imbalance. It may not feel mild or moderate to them, but they're basically able to keep upright and walk. They just don't walk very straight when they walk. Now, if a person has bilateral vestibular loss or hypofunction, they're not dizzy. Why would they not be dizzy? It's because they've lost the vestibular nerve on both sides and there's not an imbalance. There's no difference between the two ears. They're both at a zero. They're not putting out any information at all. But they do feel very off balance, and they have almost no balance at all in the dark. In fact, if you do a Romberg with eyes closed, they will fall like a tree. They also have oscillopsia, which means things bounce visually. They might say, when I'm walking on the sidewalk, the trees bounce, or the signs bounce when I'm driving. That's oscillopsia. With bilateral vestibular hypofunction too, you will also have the finding with dynamic visual acuity, which we're going to learn how to do that next week. They have a dynamic visual acuity loss of greater than 6 lines. If you remember if you did this in neuro class when you did the visual test with the head shaking, that's the dynamic visual acuity test where you're looking at the eye chart and shaking your head. They will have 6 lines or greater difference between what they can see when their head is still and when their head is moving. Like I said previously, they have an immediate fall with Romberg eyes closed, especially on a squishy surface. Sometimes they can get away with it when they're on a hard surface using their proprioception. Why does this happen? Usually it happens because of chemotherapy or ototoxic antibiotics like gentamicin and autoimmune disorders. I once had a gentleman who just had an autoimmune thing happened and overnight lost his bilateral vestibular system. He also had hearing loss as well. Now, by BPPV, benign paroxysmal positional vertigo, its symptoms are a little bit different. People can be just fine when they're still, and that's usually a hallmark of it. If they're sitting on the couch, they can watch things move. They can watch TV, whereas a person with a unilateral vestibular loss, hypofunction, vestibular neuritis, they cannot watch movement. They can't watch TV. But a BPPV person, they can. They get dizziness with position changes, and it's usually with lying flat, rolling over, sitting up, standing up, bending over, and looking up. In fact, this is sometimes called top shelf or dentist office vertigo because it's often found at the dentist office or the hairdressers when they go to lean back or when they look up at the top shelf. The symptoms usually consist of a strong spinning sensation for less than 1 minute, but they can have leftover symptoms that last for hours. Now, sometimes seniors will describe these symptoms differently, so I always test seniors for BPPV because they may not always say, I'm dizzy when I roll over in bed, or things spin when I look up. They will say that things rock or tilt, or they feel like they're going to pass out when they go to stand up. And you're thinking, well, do they have BPPV or orthostatic hypotension? And the only way to tell that is to test it. So BPPV is designated by canal. Is it right or left? Is it the superior, posterior, or horizontal canal? And do we think it is canalithiasis, meaning the crystals are loose in the canal, or cupulolithiasis, meaning the crystals are stuck in the canal? So I might say that someone has right posterior canal, BPPV, canalithiasis, or I might say that a person has left horizontal canal, BPPV, cupulolithiasis. And that's really important to distinguish because we would actually treat them differently. And we will learn more about that as we go along. But just know that if you just say BPPV, that doesn't tell you enough. You need to know which canal and which right or left, and do we think it's canalithiasis or cupulolithiasis. Vestibular migraine. Now we're venturing more into the realm of central disorders. With a vestibular migraine, people may or may not have a headache. If you know anything about migraines, you might have heard of an ocular migraine where people don't have a headache, but they see these wild and crazy things like a curtain of fire or silver flashes. Vestibular migraines are the same thing, only not ocular. They are vestibular, so they're dealing with the vestibular nerve, and they may or may not have vertigo with a headache. They might have a low-grade headache that's persistent. And usually the telling factor is if they have a history of migraines or sometimes persistent headaches or a family history of migraines. They might say, well, my grandmother had terrible migraines that put her in bed for 3 days. I don't get that. I just get sinus pressure. Well, maybe or maybe not. They may not recognize what they have as migraines. Migraines are actually much more prevalent in the population than we previously thought. Oftentimes, the symptoms of a vestibular migraine are a lot like a unilateral vestibular loss, but we can't find any objective findings with audiological testing on the video nystagmogram. We also have the coexisting symptoms of being motion, light, and sound sensitive. So that's something that we might want to ask them. Are you sensitive to light? Are you sensitive to sound? A lot of folks with vestibular issues are sensitive to motion, so that may not be as telling. But if they come in wearing sunglasses, you might want to ask them about headaches and find out if that's part of their issue. Often vestibular migraines can be episodic. They can come and go, completely gone and then come back, or they can wax and wane. It gets a little better, it gets a little worse, it gets a little better, it gets a little worse. They typically don't do well with aggressive vestibular treatment. So that's another thing. I've had that happen quite often where I have a client who comes to me where they think they have labyrinthitis. I'm treating them for labyrinthitis, like a unilateral vestibular loss, and we're trying to be aggressive, and we're 3 weeks in and they're actually worse, not better. And then I start to ask them, do you have a history of headaches? Is there any history of headaches in your family? Are you sensitive to light? Are you sensitive to sound? And what do you know? That's the issue. And so then we have to switch tactics, and they respond better to gentle habituation exercises. Basically finding things that they can do and building from there to the things that are more noxious to them and trying to habituate them to that noxious stimuli. I have a picture of Tai Chi here because Tai Chi is one of the things I have used in the past. Very, very simple Tai Chi poses to help people habituate when they have vestibular migraine. And the response varies. It's actually something that's very, very hard to remediate. And a lot of times our good old OT compensatory strategies, almost along the lines of like energy conservation and work simplification, can really help us with these folks with vestibular migraines. Post-concussive disorder. These folks can have both central and peripheral problems because they've got a concussion with a traumatic brain injury. They can also have trauma to the actual labyrinth, which sometimes causes BPPV as well. So they have what we sometimes call the trifecta. They have all three problems going on. They also might have some cognitive issues, memory problems. They also might have some post-concussive migraines, some imbalance issues, and they can be very motion sensitive and very visually sensitive as well. We have to treat these people very gently. We have to figure out where we can be aggressive and where we need to go with more of the gentle habituation. And oftentimes we're starting with sort of some sensory management sorts of things, decreasing the sensory overload that they're experiencing. And that's one of the best ways to begin with folks with concussion and folks with vestibular migraine. Now, what about stroke? Typically, folks who have a cerebellar or a pontine stroke will also have some of the other neurological symptoms that we would expect. Diplopia, dysmetria, dysarthria, and they have what I call the constant hum of vertigo. It's there all the time. It might get a little worse with activity, it might get a little better when they lie down, but not much. They feel it pretty much under all circumstances. You will also see impaired pursuits and saccades, and they will also have an impaired subjective visual vertical. They don't know where up is. And there's something called a bucket test that you can use for that. We can talk about that on another day when we're actually doing testing, not just history. They also will have they may have direction changing nystagmus, which is a surefire sign of someone having a central problem. And I have a YouTube video here that I recommend you pause and watch to see what direction changing nystagmus looks like. So I have a couple of slides here that show some of the differences between peripheral and central. In general, People are going to be more dizzy and uncomfortable with peripheral problems, but more imbalanced with central problems. If they have a hearing loss, you know that there's a peripheral issue going on. The peripheral organ is being impacted. I'm not going to read all these to you because we've talked about, this is basically just a summary of the things that we've talked about. If you see neurological symptoms, though, you have to think central. There's something central going on. If they've got double vision, if they've got any kind of coordination impairment, if your cerebellar signs are present, if they're having speech impairments, those folks need to get referred on to a neurologist. There might be something going on centrally if that's not already been diagnosed. There are also some non-vestibular causes of vertigo. People can have orthostatic hypotension or cardiac arrhythmias that might be causing vertigo. They could have low blood pressure just in general or have hypoglycemia. They also, if they have a history in their past of some kind of neck trauma, whiplash, car accident, some kind of head trauma or neck trauma that impacted their neck, they may be having cervicogenic dizziness. And that's another whole animal in itself, and they need to be referred to a physical therapist who specializes in necks. You treat the neck and the dizziness will most likely go away, although there are some vertigo things you can do as well with that. Medication, polypharmacology. Anytime you have a person on more than 4 medications, you can bet that one of those medications is going to have the side effect of dizziness. And guess what? Some of the main medications that doctors will give out for dizziness cause dizziness, like meclizine and Antivert. So we need to check and find out what medications the person is taking. If a person is anemic, they will feel lightheaded. Also, if a person is having some kind of anxiety or possibly post-traumatic stress, they could be having psychogenic dizziness as well. And it is a very real physiological symptom occurring alongside a psychological problem. So when I say psychogenic, I don't mean that it's all in their head. I mean that they are having physiological vertigo that we need to deal with. Also, imbalance of aging or multifactorial imbalance can happen to our older adults who are having multiple systems that provide input to their balance start to fail on them. Here's what happens when you have imbalance of aging. All these different systems can be impacted. People can have visual changes. They can have loss of sensation in their feet. Maybe they've had injuries or arthritis along the way that's impacting the proprioception in their joints. They don't react as quickly. They might have some muscle weakness, which, by the way, vitamin D and calcium not only help bone health, but it helps muscle health for your muscles to react quicker. So one of the best things we can do and cheapest is encourage people to get with their doctors and get on supplements with vitamin D and calcium. Fluctuating blood pressure, people on blood pressure medications cannot internally manage their blood pressure as well, and so they will have orthostatic hypotension. People can have mental status changes as they get older, and they make silly behavioral choices like standing on things they shouldn't be standing on, or doing things they shouldn't be doing because in their head they're still just as young as they once were, but and it's very hard to make the rational choice of, no, I should let someone else climb up and put the star on the top of the Christmas tree this year, or string the lights on the gutters, because that's not a good behavioral choice for me. I want you to be aware of some precautions that we need to take as we're working with patients, every vestibular patient. The first thing that we need to ask them before we put our hands on them or have them do anything is, how's their neck range of motion? Do they have any pain in their neck? Do they have good arm range of motion? Just have them turn their head, nod their head, raise their arms, take a look at that range of motion before you get started. Do they have any back pain? Because we certainly don't want to exacerbate that with some of the tests that we're going to be doing. Has it been determined that they're a fall risk? Have they fallen? Have they been injured when they fall? Do they have any circulatory issues? Now, there is something called vertebrobasilar artery compression, which can cause vestibular symptoms. And again, that goes back to finding out if they have any neck problems. If you suspect that they have some sort of arterial compression in their neck, you don't touch it. You send them to the doctor and have their doctor evaluate what's going on. You don't want to splice an artery and cause a stroke because of something that you're doing to a client. People can have autonomic reactions when you're doing vestibular testing. They can flush, they can blanch, they can sweat, they can feel like they're going to pass out. Those are all autonomic reactions because of the vestibular connections that are there. So watch for those. People don't always tell you. Make sure that they're not pushing the boundaries too much and that you give them plenty of chances to rest. People can be nauseous, they can vomit. I usually try to notice the signs that they're going to feel like hurling before they actually start to vomit, and so we slow down. But I also have a bag at the ready just in case, and sometimes just having the security of, oh, I've got a bag here, I'm not going to make a big mess, helps them be able to get through the testing. So a lot of times I'll just hand them a bag to start with as we're going to do the BPPV testing. Seizures. Rarely, like a couple of times in my whole vestibular career, I've had patients have seizures. Find out if they have a history of seizures before you start doing stuff with them. Okay, that's a good thing to find out. And what other diagnoses do they have? Of course, always something that an occupational therapist should know. Diagnostic tests. Here are some things that a patient may have already gone through which would be worth a look. Have they had an MRI or a CT scan? Have they had cardiac testing? If that's in the chart, that's good for you to review. Have they had an audiogram? Do they have any hearing loss? Have they had the video nystagmogram or electronystagmogram, the VNG or the ENG, with an audiologist to find out if they have a vestibular impairment? Read that and see if they have a documented vestibular impairment. Did they have a rotary chair test with an audiologist? Again, will help you document a vestibular impairment. Sometimes an audiologist will have already done the Dix-Hall-Pike. I look and see what they've done, but I always test it for myself. A VEMP test is also, it's a myogenic potential test that has to do with the activity of the inner ear, and that can also let you know about a documented vestibular loss. And then a posturography test is a computerized balance test. It's actually a lot like the modified clinical test of sensory interaction on balance that we're going to learn, only you do it with a computer to measure the test. And so if they've had that done, that's a great resource for you to look at. How is their balance doing? And here's what we do. Here's the questions that we ask. We get a detailed description of symptoms. We look at their past medical history, their medications. We get the occupational profile. So what? I always ask them, what things are you having trouble doing because of the symptoms that you have? And the answer might be sleep, especially with BPPV. Guess what? Sleep is an occupation, so that concerns an occupational therapist. And here are some questionnaires: the Dizziness Handicap Inventory, the Activities-Based Confidence Scale, and also the short FESI, or the Falls Self-Efficacy Scale, the FES. Those are all included on ACE in our course site. What I want you to do today in lab is look at and develop with a partner what are the occupational profile questions that you would ask, and think about when we're going to be seeing our CPRG clients that are coming in a few weeks. What questions will you want to ask them to help figure out what problems that they have? And I want you to develop your own occupational profile. I also want you to try administering to each other the Dizziness Handicap Inventory, the ABC scale, and the FES scale. Try those out on each other. And you probably won't find any dysfunction, or you might if somebody in our class has had either migraines or a concussion. Wouldn't surprise me. And see if you can figure out how you would use that information. And that is what we're going to do today for kind of a lab portion, for an activity portion. Thanks for listening. Sorry to go on so long in this boring format, and I will see you soon. Thank you.